Great. Thank you to all the panelists. I think this is really informative. So I'm going to actually start off by asking the first question. So I appreciate the comments about incorporating harm reduction, incorporating patients' perspectives, users' perspectives in the education and training that we have. And so how really undertrained we are. Do we mandate training? Do we incentivize training? Do we do this at all levels? Jeanette, you sort of touched a little bit on the CME. What about, is it all about the up and coming providers, or what about the existing providers? How do we get to where we need to get?
So I'd be happy to try to tackle that question, because it's a big question, and I think really what this panel is meant to sort of address. I would say that it's hard to mandate anything, and mandated training oftentimes doesn't really translate into good practice. So I worry a little bit about that kind of model. For me, although it wasn't part of my medical training, having good mentorship, having an institution where there were people who were doing this and modeling it really well, helped and really energized me personally. And so I think if there's ways to incentivize institutions to develop faculty who have this, and it doesn't have to be they are addiction-focused researchers or clinicians, but really have it as part of their repertoire and really can model integrated care, whether it's a primary care clinic, a general psychiatry clinic, whatever, incentivizing institutions to have faculty who can model this well. Additionally, I think one of the challenges that we had at Yale when we were creating our threat of addiction content was, well, what's this going to replace? You want to put something more in, what is this going to replace? How are you going to do that? And I think, again, some of it comes back on the faculty, but you don't have to change that much or put in new lectures or new courses. You can tweak what's already there. So we have huge focus on problem-based learning. So when you're learning about, heart valves and different things, then change the case up a little bit. Just have a minor change or push your learners a little bit further for more applicable sort of addiction medicine content, or put it into a simulation. So there are ways to do it, I think, without necessarily trying to force a square peg in a round hole, or saying that you have to do this. And that was sort of the stance that Yale took. So I think incentivizing with institutions, and then from the harm reduction aspect, I personally feel like partnering with community organizations that do that well and having your trainees spend time there is a win-win for both parties.
Anybody else on the panel? And then also just in terms of existing versus emerging providers?
It's not that one? And I put my glasses, huh? I need to see the doctor. I need to see the doctor. So we had we have successes. I think there's certain things that have to be mandated, certifications for things like we did the certification across British Columbia and then across Canada for culturally safe. Then that brought a lot of awareness, and like the stamp, and then that is from the top down. But then what gets people understanding what we're talking about is you do the slow things of bringing indigenous scholars to discuss and do this slow for the people I'm talking for the people that are already practicing. So it was a tremendous shift in 5 years. It was a tremendous shift in 5 years because people was already wanting that change, and that's something that happens in history and how change happens. Change don't happen just in the emptiness. There has to be, So we had success coming from a certification, a push, plus, you know, a Center for Excellence in Indigenous Health, also happened in the School of Population and Public Health, plus coming in every single place, conversations and rounds and bringing to discuss what it means, what is this? And a lot of people went like, wow, I cannot believe that I didn't know this, and a lot of it, and that conversation is happening, and it's going to take a long time until everybody's catching up. But this is not something that we can change in a year. This is a system has been broken for many, many years. So as far as we are doing something, I will be going to bed thinking that my day was worth. So that's for one aspect. And when I'm talking about that, is like, it's not exactly about addiction, but because we are talking about how we treat people with addictions, it goes together. And the same thing goes also when we treat people with addictions. It's different because we can have a particular certification for it, but we start the conversation. So another thing that we are trying to do is to empower patients. Empower patients is very important because they are the ones that are not being represented at all, and they're not being heard at all. So for them to be able to say, this is in the way I want to be treated, and they are now trying to be embedded across programs. So they are fighting for have representation in programs. So a bunch of us are pushing for that to actually happening. So then anybody that is trying to open a program, we are trying to make that binding. You have to have representation that is no tokenism. You cannot just have one person that you chose. They will choose who is going to be there and in what way. So at least to have, and we have not clear how this is going to look like, but you know, some pushing that is saying for the people that is already there. So that's what I
say. So the fact that I'm a neonatologist and sitting here suggests that having a broad view of who should be trained is important. I can think about in medical school, in pediatric residency, and neonatology fellowship, the amount of training I had was 0. And I have to say that, you know, this is more relevant than the Krebs cycle to me, and thinking about how things come together. So I think, no offense to basic scientists in the room, so I think structuring this early on is the way to go moving forward, and making it part of undergraduate medical education, and essentially every core residency program is important. Because, I mean, again, the trauma-informed care, that's not something I ever heard about until it was essentially on-the-job training. It's something you would think all pediatricians should know something about, just more broadly. So there are principles and parallels that are important in every facet of medicine, everything that we do. So I believe that there should be some sort of core requirement through training, and that way we sort of address the next generation. And it can't just be physicians, it also needs to be allied health professionals, all of us as we move forward.
I wanted to qualify my statements. Yes, for undergraduate medical education and core residencies, we need core training. I'm talking about, you know, more advanced CME. It's hard to mandate, but the opportunities need to be there.
Okay.
So this question is for Dr. Patrick. Stigma and clinician well-being. NAM just completed a study on moral resilience. How at Vanderbilt did you guys, what strategies did you employ for the, one, stigma, the clinicians taking care of these patients, these pregnant women and their babies? And then 2, how did you, or what educational training are you doing with your clinicians to prevent them from being burnt out? I mean, the suicide rate among physicians is twice what it used to be. We haven't even studied it really in nursing, so would appreciate your.
Well, I would say first off that we are evolving and learning as we go too. I think being intentional about trauma-informed care throughout the entire continuum and curriculum, listening to families, and talking to families about their experience, including bad experiences they have in your health system, is important. And one of the things intentionally, we know from the literature that particularly among nurses, there's a lot of burnout. When you imagine taking care of 6 fussy, screaming kids, and you may be in NICUs around the country, you're used to having sick sedated babies, right? And then you have a bunch of fussy kids, and you can't hold enough of them. So as we created new care processes, being mindful of that, how do we help mitigate that with additional resources? That's one of the reasons why we hired a full-time child life specialist to help both with the nursing staff as well as bring in volunteer cuddlers. In part, this may seem silly, but that physical contact, that is more important than the medication you provide. So I think it's being intentional, listening to having multidisciplinary teams that involve multiple different specialties. So we have MDs, nurses, social workers, we have child welfare, and from different units around the hospital, and building in trauma-informed care. But I would say we're learning as we go.
Alan.
So I have two questions. The first one, I'm going to frame it slightly rudely, because I think the blunt version of it is important. Yes, I'm sorry. I'm sorry. If there's anything I hate, it's a chair who doesn't follow his own rules. So the first question has to do with this training who and training them when. And the rude version of it is everybody thinks their specialty and what they do is the most important thing in the world. And do we really believe, I'm not questioning whether we should believe that or not, let me be clear, but do we really believe that either addiction treatment or, more specifically, medication-assisted treatment or medication treatment should be mandated for every professional who's going to come into contact with patients? And it's difficult to answer because, you pose that possibility to internists, and they'll say, what, are you kidding? We have to teach everybody to do colonoscopies, except if it's competitive. Or we have to train everybody to do cardiac exams, because look how many people die from cardiac problems. So I guess, that's my first question, and I apologize if that sounds rude, but we're a little bit the washed talking to the washed. And then my second question is specific to Dr. Oviedo, is how come you got so many meds and we don't? But who wants to start?
I'd be happy to sort of try to address the first question, because that came up a lot as we were trying to create this, thread through our medical school, which is, does everybody really need to know this? And so we kind of kept going back through multiple iterations and really developed the core content that everyone should have some minimal exposure to. And again, trying to, at least at the UME level, not necessarily say that everyone needs to be an addiction specialist, but certainly giving them role models who are addiction specialists that hopefully someday they'd want to have a practice like or a research agenda like. So I think that's a big part of it. And I think along those lines, trying to support all medical schools to have really an addiction fellowship. All medical schools pretty much have a cardiology fellowship, right? I mean, how are students going to become interested in this field if there's no role models, there's nobody to sort of elect to spend time with to learn what they do? And so I think that that's something that could be suggested, is, trying to expand those advanced training programs, not necessarily because we expect that we are going to graduate more people to do that, but it's a probable unintended consequence of it. So that would be my view on that.
I might just point out too that states are doing this. They're mandating CME for opioid prescribing. One of the possibilities would be to insert part of this in that sort of training that's already there, to expand the knowledge base. I mean, even for me, my opioid prescribing is in the ICU. I still have to do state mandated opioid prescribing, and that education on medication assisted treatment, I think, for the broader public.
I'm sorry, is that to treat opioids, or is that in life you have to do that as a part of?
No, you have to have a license, and increasingly states are requiring that.
To
Some
have
sort
a pediatric license?
just a general medical license.
That's what I mean.
Yeah.
Okay.
Just a general medical license, and the board, the state board, and increasingly we see states doing that. So it's a place where if opioid prescribing is important, knowledge of this I think is important too. And even if this was just of that 2 hours 30 minutes, I think it would be beneficial in terms of CME for folks to be exposed to.
So, we have, I give you the list. So besides the classic methadone and buprenorphine, that methadone is the most studied and used long-acting opioid in Europe and France for just, how things went, introduced buprenorphine instead of methadone. And for a long time, those were the only two meds that they had. But then they don't work for everybody all the time. So they introduced slow-release oral morphine that they had it for pain medication. And they did several studies and trials. And they showed that they were as good as a methadone. Always methadone is the gold standard comparator because it's the one that we know the most. And it shows, so far, the better retention. And they added in Europe, slow-release oral morphine for those patients that might want and prefer and do better with a different long-acting opioid. So that was recently incorporated in British Columbia. So far, we are trying to make it not part of the addiction treatment system. We are prescribing it off-label right now. And then, as you know, several countries in Europe have diacetylmorphine morphine licensed. We couldn't get the license with our first clinical trial that we did with our research group. So for that, we did a second clinical trial when we brought hydromorphone in a double-blind study. And that one, we were able, because it's licensed and opioid analgesic, so we are prescribing it off-label, still as a pain medication, but we are getting across Canada with the blessing of Health Canada under the opioid crisis. So those 5 medications are able to be prescribed across Canada, with the only problem with diacetylmorphine morphine that is not licensed in Canada, so you need to bring it overseas. So people don't actually do that. The only people that do that is our clinic, Crosstown Clinic. So across Canada, you can access 4, and logistically, but in our clinic, you can access 5.
Huda.
Thank you. First, I want to say I was very moved by the personal report. Thank you for doing that. And the sense of the multi-generational impact that it has on people's lives. And I also echoed your point about stress and early life abuse, because I think sometimes people just think that the problem starts with the drug, but the problem can start in many places, social, genetic, developmental, and so on and so forth. And the more we understand that and bring it to bear, both in prevention and treatment, and I hope that, as we deliberate as a committee, we can find a way to incorporate some of that input that you gave us. So that's just a general comment. I have 2 quick questions. One is tianeptine ever used? Do any of you know it, that drug? It's an antidepressant used in Europe, and they never knew exactly how it worked. It was never used in the United States, but because it was never licensed. But recent work shows it activates the mu opioid receptor. And I was just wondering if it's on anybody's horizon, especially Canada, since we're talking about Canada. No? Okay. Just leave it. I'm dropping it here, and you guys can do whatever you want with it. Okay. So my question is about then the developmental side, because it sets the stage, right, for the rest of the person's life. And I really appreciated the point that having a premature, immature brain develop into this world has known very negative long-term consequences, and so going to term is critical. But then you said that those kids that are in withdrawal postnatally are okay, and I'm curious about what you mean by that, and what information you think would be useful to have about that.
Yeah, hard to qualify things in a quick talk. So the literature on long-term outcomes from neonatal abstinence syndrome is confounded a lot by a few things. First is alcohol use. We know that alcohol use is very common among some of the work that we've done looking at pregnant women who misused a prescription opioid in the last year. I think 25% also used alcohol in the last month. We know that alcohol is the #1 cause of preventable cause of developmental delay in children. And then the social environment is also not well accounted for in many studies. When we look at that together, what the study suggests to me are some issues with strabismus, some attention issues, perhaps some language issues. So there are effects there. They just don't appear to be profound effects. And one of the things that I think is important for us is to remember, in part because of the narrative around what we did with the cocaine epidemic, where we had crack kids, a lost generation. It's important that we sort of mitigate some of that language as we think about how we attack this problem. We need large, rigorous, prospective studies to follow infants that are here. In the meantime, we need to be utilizing the resources, many of the workforce pieces that I put there. Early intervention services, as part of IDEA Part C, they are underutilized, and we actually don't have great data to understand how well they're utilized. So infants should be referred for speech therapy, physical therapy, occupational therapy if they are, and there's different rules by state, but generally neonatal abstinence syndrome always applies. That's not well coordinated currently with child welfare. So we need to make sure that infants are hitting their developmental trajectories, they're getting plugged into the available services, and that the people that are providing the services also have the same training in terms of stigma, understanding addiction.
So is there any study that has followed up these kids into, for example, adolescence or young adulthood?
There aren't any large studies that I'm aware of. Now, look, there are, and a lot of the studies that are there are older studies from heroin or methadone. Some of them, and again, they are generally underpowered. They're small, and the ones that I remember off the top of my head are, to before adolescence. There just aren't large prospective studies, and again, part of it in the sort of more contemporary epidemic too. We don't have great studies in terms of Subutex or buprenorphine products. There are some, like from the mother study that was published. There have been some long-term outcomes from that. But that's a very specific population. We see among our 150 or so opioid-exposed infants, some are engaged in our clinic prenatally, but many of them are not. And so we need to understand that. The other thing that we need to understand is how does our treatment of infants with drug withdrawal matter? So I've done some work to look at infants that are sent home on medications. Phenobarbital is frequently used for hospitals to treat neonatal abstinence syndrome as an adjunct. It's potentially neurotoxic. And we did a study recently looking at Tennessee Medicaid, and 1,000 infants or so, about half of them were sent home on a medication. 90% of that was phenobarbital. And the infant who stayed on the longest was on for 200 days. And 200 days is a pretty long time for drug withdrawal to last in the population. A lot to say, mouthful, but there's a lot that we don't know. We need some more literature.
Just one more little thing. The track record for things like using steroids, for
Yes.
example, in early life,
Yes.
and how long it took us to discover the
Yep.
damage that it can do. So trying to understand where the needs for knowledge is here. That's
Neonatologists have PTSD from steroids. Yeah. Right. Yeah.
Yasmin.
It's funny, a number of the things have already been asked, and it was the thing about the long term and about, as a neonatologist, and passing on your information to the next, and to the pediatrician and to the other people around you. So what is that infrastructure for not just the mom, but for the babies in terms of especially the long-term care?
It's completely uncoordinated. So we are, boom. So just to be direct, and it's not just, we are actively working on that space. That's our next PDSA cycle in our work. With that said, federally at every state, it is not well coordinated. There are multiple players for both mom and baby, and they operate in silos. In the most recent, the Support Act, and as well as multiple different pieces of legislation that have passed this year, Families First, as well as some other things, there are changes to the child welfare system that may help break some of those silos. So we can now use funds for child welfare for prevention to keep families together. The legislation that passed last week had something called plans of safe care. It's plans of safe care that are supposed to keep the infant safe, but also consider the treatment needs of the mother. So states are required to write these plans, and they are broad. They include home nursing visitation, Medicaid. The question is, how is that going to actually be done? A GAO report released earlier this year found that it's not being done well, generally. But I think we are at a unique place where we could use these mechanisms, these new programs in place, to where we can begin to coordinate things better. I think we need an intense focus. Look, we can reduce length of stay, and we are doing that. But where do those resources go?
Right.
If we could push those resources in the excess length of stay towards home nurse visitation, one day in my hospital can buy a whole lot of home nurse visitation.
Yeah. And so for Jeanette, at Mount Sinai, our students have been really great because we've been this whole thing of addiction is medicine. And a lot of the students, you think, oh, I'm going to become a cardiologist, but you have a patient who's been using stimulants for a long time, so it was easy to incorporate, and like you said, the students are today, because of the opiate epidemic, they want to be the ones doing this. So we even have students asking us and now rotating in our opioid treatment programs. And that's another thing that actually helps our staff, because many of the people out there in the clinics who are not part of the main hospital, they don't really get that many physicians and residents and fellows, and it makes their lives also more integrated into regular practice. So I think that it's like teaching education of addiction is medicine. But a question I have actually comes back to Dr. Oviedo. The majority of people you said that are using the injectables, they are mainly like 20 years or so. But what percentage are new? So I'm just wondering how many, in the different stages of someone's substance use disorder, do you find that there's certain populations who really go for the injectables? And I was just wondering the patterns of the populations, like the demographics or so.
So, can you hear me well? Yes? So there are kind of two parts of that question. The first part is what we have done in clinical trials. So the majority of what I'm going to tell you first is our target population, what awful way, target population. The people we went after to show effectiveness. So when we're trying to look for effectiveness, I know I'm in a very highly educated audience, but I do this because I don't want to confuse with when we go as a program. When we go as a program, all bets are off. When you go as a program, you are just looking at a person. When we go in a clinical trial, I'm trying to see what will be the group I'm going to show effectiveness. So we went for people that tried oral treatment in the past and right now not doing well. Every clinical trial, they find it not doing well in a different way, and I define it not doing well in a very pragmatic way. If you're injecting today in the street, you are not doing well. That's my definition.
Okay, thank you.
I got another pushback, but pushback against me. I challenge you. So in that way, we had other criteria. The thing is, how the system works, all of us ended with a similar group. All our clinical trials ended with a similar group because the system squeezes the same people everywhere. You know, we are a very perverse system. We squeeze the poorest, the most vulnerable, those with the worst childhood, with the families that couldn't care for them. So we ended up with the same population. So we ended up with people that at back time had average my age, so we will grow older together. With 15 to 20 years injecting in the street, that tried 5 times other treatments that were in and out of abstinence-oriented treatment, and then some of them never even tried once because they knew were not ever going to work. So what we ended up also were, with 35% of them indigenous background, we did the most we can to oversample for women, gender because they're always undersampled, so we wanted to make sure we could do some analysis. So the people, when you go to our clinic, the people you see is the people that the system has failed over and over. Once we moved to a program, it was the age average dropped a bit. So then, of course, the effectiveness goes. So what we are trying to do now is, as a program, is not to offer you as a second-line treatment. And I said us, and there is people that, of course, will like to only leave this as a second line because they're scared. But we want you to say some people have tried for 2 months and move immediately to oral because it's very quick titration with injectables. We titrate you in 2 to 3 days, so you immediately, but after a month and a half or 2 months, they say, hey, I like you. You seem like a nice person. You treat me well. And I honestly don't want to inject anymore because you are talking me out of it. Because honestly, I don't want my daughter to be injected. Do you want your daughter to be injected? Certainly not. But we cannot make our daughters to do anything. They're 6 and I cannot make it do anything. But we are trying to, in this delicate balance of shared decision making, that is actually, I want my daughters to do what I want. But it's shared decision making. I'm trying to. So we use sometimes with the younger folks that are coming as, come, don't leave, please. Don't go and inject whatever, fentanyl in the street. Stay. Stay with me. And in this day. And I want to say one thing about this. The first question, I got thinking. You asked that, and I needed to think. Do we need this addiction specialty? We're focusing too much on the physicians. Injectable treatment is a nurse-driven program. Mm-hmm. The person that sees the patients all the time are the nurses and the counselors. The physician sees them once a month at the most. So please let's not forget that there's a very strong interdisciplinary teams. Exactly. So maybe it's not that we don't need an addiction specialty. We don't need that old school addiction fellowship. We need interdisciplinary ways of thinking and do it not just for medicine itself, but also when the nurses. The nurses are the ones that keep our folks
take
alive.
care of all the babies and all the things. Yeah. I mean, and you bring up an important point, and I think to Kathleen's story and a number of other people, I mean, it seems like a lot of the research is very biased on the populations that are studied, so we don't have a very broad understanding, perhaps, of, the most severe or so on. But thank you.
Laura.
Thank you, guys. This has been a great discussion.
Mike Moore, speak more into it.
Closer. Here we go. So I think we do a good job paying lip service to the importance of the family in recovery, and we don't do a good job really bringing family members in part because of confidentiality. We certainly don't do a good job providing families with relevant information or education. So we're tasked with writing a report, and so my question, kind of more to the two of you guys, but anybody who works with families, is how do we get the information and the conclusions that we come up with from this committee out to family members and patients and advocacy groups that could translate if that's needed? What is the vehicle to do that?
I'm eager to respond to that because I've been thinking about it a lot over the last few days. There's the roller coaster nature of this makes your information gathering either an urgent crisis situation or a longer term, how do we live with this situation? And when you speak to the challenge of working with families and they're alongside their family member, the person they care about, there is that challenge of whether we can be part of their decision making. Do we overstep? Do we not overstep? I've made, I believe, every possible mistake in that arena. And the challenge for us early on, I'm a researcher. I'm a person who likes to find information. I was on it. I was going to fix everything. And the best information that I could find was through grassroots or information through social media. Regular internet searches, calling doctors, the normal structural institutional avenues were very siloed and essentially shut you down when you would get information about one aspect or information about another aspect. And so I think there's both the moment which is still happening when someone has just overdosed at your house and the emergency squad has left because the person refused to be transported. What do you do with that person for the next 24 hours? We've been there on numerous occasions. They're not in a good enough frame of mind to be able to seek help. They're not threatening to harm themselves or others, so you can't get any immediate kind of psychiatric help. And there you are, and you've got to go to work, and you've got to go to the grocery store, and you've got, a kid that might be running a fever. So there's that kind of information and resource. And I know that there's the thought, well, there's hotlines, there's things you can call. But my experience has been that, again, they are also very limited and siloed. And then I think more importantly also now that I'm seeing, at least in our family, in our community, is the longer term, how are we living with this? The ideas about an integrated, comprehensive approach, that sounds wonderful, but how do you really put it together realistically and let the families be part of it, but also be part of it in a healthy way?
I mean, I think this is sort of the age-old problem of the gap between sort of research and policy and the public. And I think for the committee to, if you haven't already, give some thought to what kinds of advocacy organizations are you willing to partner with and work with when you get to the dissemination phase of your findings. So organizations like mine, we probably don't agree politically on everything with all members of the committee, but we do have broad reach, and we have a strong communications team and lots of experience in getting the word out and sort of translating more technical findings into lay language. And there are lots of groups like ours that do that. But I think those partnerships aren't always there. So I think it's thinking strategically as a committee where those leverage points are and who you're willing to work with and how you're willing to do that. And sort of, agreeing to disagree on some points, but having the shared goal that there's information that all folks need that needs to get out there. I mean, that's one set of challenges. And then the other, of course, is using media in ways to disseminate your recommendations and findings and doing that in a really targeted way so that it reaches the folks that you most want to reach. I would also say, to the extent that you all are going to make products yourself that are meant for a general audience, again, that's sort of my mantra, but to bring in families and people directly impacted to help craft those products so that they are in formats and languages and vehicles of dissemination that make sense to people. Because it's hard for those of us who have way too much education to necessarily know what all of those are if we don't talk to folks on the ground. Like where are they getting their sources of information? What kinds of language and products make sense to them? What kind of groups are they going to for information? And then starting there.
I'm going to ask a follow-up question, and then I'll get to you, Scott. So this is my question is really about educating the public and maybe law enforcement, which is that a lot of media now have what I see as a very typical story, which is a middle-class, white, usually young female in the story, and about how drugs has, destroyed her life, family lives, and then with treatment, there's this great response. But as a provider in the Bronx, who's treated the vast majority of people of color for decades, that storyline does not feel right to me. And so I'm wondering about this sort of education and training to the broader public, the narrative. What should that look like? How should we approach that? In terms of really thinking about some of the social justice issues that communities of color have experienced?
Well, I think this is something I care a lot about. I don't know if Helena's back in the room, but Helena Hans and I have done some media analysis looking at this very issue, and it's not just your perception, right? There actually is quite different coverage. And so, I think there's a couple of things that are going on. One is that, people of color have not been afforded the same kind of backstory and humanization and narrative that white folks have in the media. And so, I think is part of the solution then providing those kinds of humanizing stories among communities of color? Maybe, probably. But I think the other thing is there's been this sort of lack of attention and lost history on what the history of the struggle of addiction, but our responses to it in communities of color have been, right? So it's not just that we're now ignoring what's going on in communities of color, it's that our policies of criminalization, the war on drugs, have devastated those communities, and we're not talking about that either, right? So when we think about the kinds of narratives we want to tell now, like, we have a lot to do in terms of thinking about how we're repairing the harms that have been done in those communities, what's happening in those communities now, and the kind of attention that families and individuals and communities are receiving. And that's, partly a problem of the media, but it's obviously a larger political problem. And, as overdose deaths continue to climb in communities of color, are we going to see proportionate attention in those communities? I don't think that's happened yet in New York. So I'm glad you raised that question. Thank you.
When we started our Salome clinical trial, the one about the hydromorphone, and the moment we started, we had a full plan for the media communication. It included the clinical team, the patients, and the research group, plus the communication team at the organization we were working together. We had the vision and mission of our group. We sat an entire day with patients. We defined our values, what is that we wanted to communicate, who is going to be the spokesperson. Patients decided who is going to speak. Every time we decide a call, we receive a call from media. I received media training twice. Patients received if they wanted. If they didn't, we had our outreach worker that will be before the meeting with the media, sitting with him, going through, not telling you what you're going to do, but prepping. So, we're vetting who is going to talk to us, particularly to the patients, to make sure our message was not going to be distorted. At least we're going to do everything in our possibility. We put so much work for that not to happen, because we were not going to have this idiocy. Free heroin, that's not going to happen. This was not, we did not want to happen, because what we were doing was providing care. That is what we do. And the patients, we're going to say whatever they feel they want to say. We will not telling them, you're going to say this and this and that. No. We want patient representatives every time the media called. We were there, all of us, together. And then we had so much media that at some point was just like, yeah, whatever, you do it. So, but all the time. It was a lot of work to try to maintain that control, but I think at the end it kind of paid off. A couple of times, when they don't give you interviews, everybody can say whatever, but you will see everything they can quote from us. It will never stray out of message, at least for us.
I would say, beginning to acknowledge the fact that the role of race clearly played a role in how we responded to the crack cocaine epidemic to how we're responding now. I mean, again, you can just look back to Time Magazine versus New York Times today to see that play out for pregnant women. And beginning to learn, first off, the history of that so that we don't repeat it as this epidemic evolves. We know that it has in state laws for pregnant women, specifically targeting pregnant women to criminalize them, to arrest them. So Tennessee had a law in the books for 2 years that a pregnant woman could be charged with a misdemeanor if she used an illicit substance and it harmed the infant, and the harm was pretty broad. So we have to remember our history so that we can not repeat that moving forward. And I think it's incumbent upon us as providers, as people who do research, to help frame that for the narrative for both the public and the policymakers, so that we can remember that all communities are affected by addiction, and we have to be mindful of the language. In my space too, the other thing that comes up pretty frequently is the whole born addicted narrative, which is stigmatizing by itself. And so, for us, one of the things that we have been mindful of is we don't generally do tours of the unit anymore because of the way that imagery is put forward. We are careful in the way we phrase things, and in interviews we correct folks that we talk to. But that sort of messaging is really important as we think about ways to move forward, because public perception changes policy. Policy affects people. Public perception affects stigma, and that affects people too.
Thanks. This was a great panel. Really enjoyed it. My question is for Jules, because your work is so different than the work that the rest of the folks talked about, right? We're talking about, and a lot of the times what we've been talking about is individuals, right? So treatment of the individual. And I thank you for bringing us back up to the 30,000-foot view, because we have to think about that. I mean, it seems very important, because according to Eugenia's work, it doesn't really matter what the drug is that you give. If you give enough of, people do okay. So my question for you, you mentioned outcomes, and that's been a thing that we've talked about a lot as a committee, but not at the individual level, right? Like, my question for you is, like, what kind of outcomes are there for policy changes at the 30,000-foot level? Like, what are you looking for in, I don't know, society? Tell me what kind of outcomes are things that are measurable that would help inform our report.
That is a hard question this late in the day for me. I may have to get back to you on that. I want to point to David, though. I feel like a million years ago we did work on looking at different kinds of social determinant outcomes. There's a report called RULER, so I don't remember what that acronym stands for. So I don't have an answer off the top of my head for you, but I know that there's been sort of work done in that area. But I think it's looking at, sort of community level indicators of sort of health and well-being. So it could be anything from, civic engagement to levels of employment to, broad sort of health outcomes, indicators around infectious disease, that kind of stuff. But I'd have to give it more thought to really pin it down.
I will. I'm just going to move myself up here.
There we go.
That's right. He comes from the dark.
Wow, this is serious.
So your question and your response gets me thinking about some work that's going on at the Robert Wood Johnson Foundation on the culture of health. And they have 4 How's that? Yeah. Well, just to reel back so everybody's on it, what you were talking about, what comment you brought up, thinking about the Robert Wood Johnson Foundation's Culture of Health program, it's got 4 action areas, and the one that's gotten the least amount of attention is Action Area 1, which is making health a shared value. And part of it is when you say that, it's like, oh, well, yeah, sure, we should all have shared values, but what's that, and how do you go about doing it? And so there's been a process over the course of more than a year to try to unpack that a little bit. And it's really looking at things like mindset and expectations within a community or within a society, and then building that towards a civic engagement so that you've got the participation and the cohesion that comes with that. So it's really looking at what's the kind of research that's needed in order to shape, mindsets. If we're saying, this is how we've always viewed things and they can't be changed, how is it that they can be reimagined, and how is the process for change? And there's certainly literature on that in terms of, for example, tobacco and what's happened over the decades with that. And so if we're going to be thinking about substance abuse treatment, right, and I'm going to call it treatment and not go through this assisted this and that and so forth, then it's how is it that you look at where is our mindset on that? What are people's expectations? How is it that we build sort of a civic engagement, participation towards shaping that as an approach, right? Is that a shared goal to then have that as a value? So there's work that's going on in that area right now. There have been a few projects that have just been funded, and a fair amount of it is dealing with how is it that you understand where people are coming from, right? And there's not a monolithic view in what you're dealing with, such as in gun culture, right? There's not a single gun culture if you're going to look at it that way. Neither will there be for treatment. And then how is it that you address each of those through communication? What are communication strategies and at what level? So there's work that's going in that area, not directly related, I think, to what we're talking about today, but that's what you stimulated in my thinking. So thank you for calling on me.
So we have 1 more minute, so one last comment.
Oh, that's a lot of pressure. I was just going to say the science of policy analysis needs to be advanced too. I know there are folks at Rand Corporation just got a large grant from NIDA to begin to work on pushing that forward. Policies typically happen at the same time. They're very collinear. Part of the evidence base and the methodologic base that needs to move forward is understanding how various policies affect individuals and populations, and we've got a way to go on that too.
Great. So again, I want to thank the panelists for your time and your presence, and this has been a great discussion. Thank you.
And I'll add my thanks, and thank you to you, Shinazo, for chairing this. And see you at 3:30 sharp here. So far, so good.